Welcome to the Friends of NPACE Podcast, brought to you by Haleon. As a leading global consumer healthcare company, Haleon is dedicated to delivering better everyday health with humanity. Known for trusted brands like Advil, Excedrin, and Voltaren, Haleon leverages science, innovation, and human understanding. Haleon is proud to collaborate with NPACE to educate healthcare professionals about our pain portfolio and the latest healthcare information. For more information, visit www.haleonhealthpartners.com.
Hi, everybody. Welcome to the Friends of NPACE Podcast. I am super excited to be with you today on today's podcast because a couple of things are happening. We are super excited that we have a continuing education credit for today's topic from a generous grant from Haleon. So a big shout out to them, educational grant. I'm also super excited because the person we're talking to today, I'm getting to meet her for real after reading about her and reading her CV. And I'm so excited to talk about the topic, which I think is very important. I have a lot of patients who have this issue, so we'll get into what the topic is in a second, but I want to introduce who's here with us. Dr. Heather Jackson is a pain clinician practicing in the supportive oncology and palliative care clinic for Vanderbilt Ingram Cancer Center at Vanderbilt University Medical Center. She's also an associate professor of nursing at Vanderbilt University School of Nursing, as well as the Vanderbilt School of Medicine, and founding board member of the Pain Medicine Academy of Advanced Practice Providers, PMAAPP. Huge shout out to that organization because we know other board members of that. I think it's so important. You're a nurse scientist. You have advanced use of acupuncture. Oh gosh, we should do a session on acupuncture. I'm sure the listeners would actually love to talk about that. So let me write that down here in a second.
I was going to say, get your notepad out, Terry. Yeah.
Yep. Everyone knows I take notes. In the treatment of pain and opioid dependence. So I'm going to put acupuncture down here. In adult, neonatal, and pediatric populations. Did I get it all?
Yeah, you got it. Thanks, Terry, for the wonderful introduction.
Thank you for being here. And what we're going to talk about today is pain and sleep, that intersection of where when one goes bad, the other goes bad and vice versa. So thank you so much for being here today.
Yeah.
Okay, I wrote down acupuncture. Now we can move on. So in season 2 of the podcast, because we have healthcare providers, I'm actually cataloging everybody's journey on how they ended up in the healthcare profession because it's wildly unique. So the first question out of the gate is, how did you find yourself in nursing?
Yeah, that's a great question, Terry. And I'd love to see your qualitative feedback on that because I imagine you do have some great stories. Mine is going to seem really random. As a little girl, my mom was a nurse, and I always saw in multiple situations, if it wasn't just for me, it might be for my family members, for my friends that fell and skinned their knee, or teammates when I played sporting events. She always knew the first line intervention. She always had that calming presence and always seemed to know how to react and what to do. So I wanted to be that person. That's how I got into the medical field. I wanted to be able to react in the appropriate way in medical situations. And I knew one day I wanted to be a mother. So thank goodness I did go into this profession because I ended up having 2 very energetic boys, and I've certainly put those skills to good use.
2 boys. Your house is always super fun.
Yeah.
I get it. I raised 2 of my 3 were boys, so I get it. Well, a big shout out to your mama for being a nurse and being the neighborhood person that everyone went to. I love that. Thank you for sharing that. I am interested in how you got into pain medicine and palliative care. What was that journey like?
Yeah, so pain, I was actually the first interventional pain nurse practitioner at Vanderbilt University Medical Center. And they started the practice around 2010, and sort of the height of the opioid epidemic was really starting to climb. And they said they needed a advanced practice clinician to help with seeing the more and more pain complicated scenarios, providing a comprehensive multidisciplinary plan of care. So I learned that specialty practice. I worked there for years, and then I actually transitioned over to the Cancer Center for my leadership role as the administrative director of advanced practice. And so then I was able to transition into supportive and palliative oncology. So I was able to put those pain skills to use for our oncology population.
I love that you were the pioneer, though, in that interventional pain management. Did they know what to do with you at first, or were they like,
Oh, they didn't have a clue, Terry. I think my orientation I first was watching the intake in the clinic. So that was a whole other research initiative that came out of that, is how do we train specialty nurse practitioners, as you can imagine.
Yeah, I love that. Okay, that's a whole nother topic too. How do we train specialty nurse practitioners? Okay, we're gonna have a leadership talk on that too.
Yes,
Thank you so much
it's
for
another
thinking.
passion of mine for sure, and it's one that I learned boots on the ground.
Definitely. I love that. How most of us learned a lot of things if we've been practicing a while. We
Right.
were the first. So I have you here because you're clearly a pain expert, but our audience is primary care providers mostly. Why does that intersection of pain and sleep matter? Why should we care? And how do we go about getting started in evaluation?
Yeah, why should we care? One answer sums it all up: prevalence. The NIH reports that 50 to 70 million Americans have sleep disorders, and 1 in 3 adults don't regularly get the recommended amount of uninterrupted sleep that we need to protect our overall health. Experts generally advise that we get 7 to 9 hours of sleep nightly for better health, and the research shows that getting enough quality sleep at the right times is vital for our mental and physical health, quality of life, and even safety. Regarding pain, according to the CDC, chronic pain is highly prevalent across the globe and in the United States. Studies estimate that 20% of adults worldwide experience chronic pain. So, understanding this prevalence, risk factors, impact of pain, and disrupted sleep on a person's quality of life is crucial for developing effective strategies and managing and treating conditions.
Okay. Nope, that makes perfect sense. I did take notes. 50 to 70 million people have
Right?
sleep disorders. That's like a third of the population.
Yeah, yeah. And if you think about it in your own life, your own family, we all know patients that come in and have that as an aftermath. They're coming in with a primary complaint, but when we really dig into it and find out what their problem list is, that's usually right there.
Yeah. So with the prevalence being so high of both of these things, sleep disorders and pain, should we just be doing this in general physical assessments, asking about sleep and asking about pain? Where should we start?
Yeah, honestly, Terry, it is on my algorithm. I usually get to the primary complaints with patients, but in my new patient assessments and then ongoing, I try to think about it. But especially when I have that time for that new patient consult, one of my last questions before I proceed on into my plan is, how are you sleeping?
Okay. I like that. And of course, we do a pain assessment.
Right.
So, talking about that screening, if someone says, I'm not sleeping great, then what do you do? How do you screen for sleep disturbance or disorder? And where does pain intersect in that sleep assessment?
Yeah. Yeah. So great segue in. As you referenced, in our vital signs for pain, we typically are getting that flag. So we usually have the numeric rating scale 0 to 10, 0, no pain at all, 10, worst pain imaginable, to sort of give a clinician the intensity. So we would want to further go on with that data to inquire, is that pain being managed? And then further, is it disrupting sleep? And then there should be an awareness for a clinician when they're treating acute pain. Optimally and quickly treating acute pain actually reduces the risk of developing chronic pain. So clinicians should sort of keep that on their radar and keep that in mind. When we're screening for sleep disturbance, it can be as simple as just asking, like I said in my questionnaire, how are you sleeping? And then that often opens a dialogue of symptoms. There are questionnaires and tools like the Athens Insomnia Scale and the Functional Outcomes of Sleep Questionnaire, and that gives an assessment of the impact of sleep disruptions on their daily life. And then sleep diaries can be really helpful. So
Okay.
factors I would look at for those sleep diaries would be like bedtime and wake up times, their patterns, the time it takes to fall asleep. Are they waking up in the night? Are there daytime sleepiness and fatigue symptoms? What's their sleep environment like? And then are there any medical conditions or medications that might be impacting?
Oh, I love that you brought that up. The medication impact on
Yeah,
that. Yeah. Most of the time when we see patients with these issues, they have other chronic conditions. And
exactly. Yeah.
um, so when you're assessing for pain in this and chronic pain, What do you do with the patient that no one's ever, like, what's your pathway if they're like, yeah, I hurt all the time and I'm
Yeah.
also not sleeping? Like, what's the pathway to go? Do you do an intervention first to try to get them there while you're working up where this is and what this is?
Yeah, that's usually where I get into the further questioning. And if we have pain with sleep, then I'm asking them, are you waking up because of the pain, like you're sleeping? Because I have patients that often happens with, especially cancer
Okay.
pain, where the medicines aren't lasting long enough and they are awaking in pain. Or when I get into more of a dialogue, oftentimes it's not the pain, it's more of anxiety or thoughts racing through their head related to something else going on in life. And obviously, that's a whole other algorithm.
Okay. Gotcha. Um, yeah, there are other things that wake us up even though we hurt all the time.
Right,
And sometimes adequate sleep can help, right? With
right,
the pain and the
right.
perception of pain. Interesting. Okay. We talked a little bit about why sleep is so important just for quality of life. Um, but on a physical health kind of well-being scale, does it have any other effects besides alertness? Are we talking blood pressure or cardiac effects,
Yeah. No,
metabolic disease?
honestly, like, yeah, it's like, yes, yes, yes. Like, whatever you name, sleep impacts it. And I tell my boys this all the time. Your sleep is essential. And you can tell when they've been a little sleep deprived as a mother. And I'm sure they can, I mean, not so much me, but maybe you, Terry, they could tell if you were sleep deprived. Just kidding. I think everyone
Yep,
can tell when Heather hasn't had enough sleep.
absolutely.
Right.
Um,
But
I,
yeah.
I found it even more in my patients who already have mental health issues or
Yes.
I'm treating anxiety or depression. I mean, the second they're not sleeping, that will crank up symptoms,
Right.
2 or 3 fold. Um, does it do the same in pain? So if you have someone who has a sleep disorder for some other reason, or they have anxiety, if they're not sleeping, then does that affect their pain perception? If you can get someone sleeping, is that kind of part of the
Yes.
battle?
Yeah, so just thinking what sleep impacts. So it's crucial for maintaining our overall health and well-being across all stages of life. And really, it's pertinent to our brain function. For children, it's essential for growth. It regulates our bodily systems like our heart, metabolism, respiratory, immune systems. Adequate sleep reduces the risk of chronic health issues like heart disease, high blood pressure, which you were hitting on, obesity, metabolic syndromes. It impacts our hormonal balances, our ability to learn and even memorize, ultimately impacting our cognitive performance. So, insufficient sleep can even lead to hunger, decreased physical activity, and it heightens that susceptibility to infections and respiratory issues, which you can see would impact a plethora of issues in the primary care setting.
Oh my gosh, that list was so long. I tried to take
Right?
notes, but I'm just going to have to come back
Yeah.
and listen to our podcast. I mean, all the things, right?
Hmm.
So we need that time, the downtime, it
Right.
sounds like, for our body to repair. Okay.
Absolutely. Body to repair. Yeah, that's the key right there.
Yeah, maybe we'll fix the underlying issues. So you screen initially not only for pain but chronic and how they're sleeping, difficulty falling asleep or staying asleep, that sleep diary. Do you then initiate treatment and go back to that same assessment to see kind of where you were?
Yes, I do routinely assess. And things I'm looking at when I see an intersection between the sleep and pain is I want to be certainly concerned about that because as we can see, all this sleep, it certainly is going to impact the holistic person. So when I'm treating pain, I tend to triage the relationship first by managing that pain and then screening that sleep disturbance because I just want to make sure that the pain is managed and well controlled before we look into other things. And
Okay.
I do find it helpful to think about the biopsychosocial model of pain. So those are three factors that have an intersection in how we perceive things and how we perceive pain specifically. So it's
Okay.
biological, psychological, and social factors. So if we ensure protection of those factors in addition to our sleep, overall you're going to be promoting well-being for the patient.
Okay. I like that. Treating the pain first and thinking about that biopsychosocial model.
Yeah.
Okay. Nice. In the treatment or even the assessment, what are some of the red flags that we should consider about pain or sleep? Um,
Yeah. I get really concerned if I hear that the pain is waking a patient. I don't like to hear that. That to me seems like it's unmanaged pain. And then if I'm hearing in the daytime that they're sleeping throughout the day, that's telling me we're not functioning. So I don't want to hear that we're missing out on social interactions or attending events, perhaps being functional at work, because we're too tired and sleeping during the day.
Okay. Sleeping during the day or missing function. So it's that social again.
Right, right.
Pain that's waking someone up nocturnally. That's pretty significant pain.
Yeah, yeah.
Okay. We'll keep those in mind. All right. So let's talk. We've diagnosed the pain and the sleep. We're going to treat the pain first and see where we are. Let's talk medication options. Where do we start? Do we consider over the counters? Is it stepwise?
Yes. I say it's stepwise. First and foremost, I spend a lot of time when patients complain about sleep disturbance on sleep hygiene. I want to give them self-management tools, and I want to make sure that we don't just assume that has happened, because honestly, Terry, 9 times out of 10, when I face this with a patient, if I do some good patient education and recommendations, a lot of times they're able to self-correct it. I might have to do some interventions, but this is my predominant treatment. So oftentimes when you start those conversations, multiple factors are identified, such as not establishing a routine, sleeping during the day versus night, lack of activity during the day to promote sleep at night, interventions for a sleep environment like no blue light, no TV, putting a fan in the room, and ensuring overall that the brain is programmed to know the bedroom is a place for sleep. So not doing other activities in the bedroom. But if I need to go to medications though, over-the-counter options usually contain antihistamines. Melatonin is commonly used. There is some research supporting cherry juice, and then complementary treatments. Chamomile tea and lavender essential oils are common treatments that are used to promote relaxation and do have a calming effect.
Okay. I'm writing all these down. Cherry juice.
Yeah, cherry juice, right?
I love that. I want to circle back to sleep hygiene because I agree. I work in primary care. And a lot of times when we do that assessment, people tell you, oh, yeah, I'm in the same bed. I go to sleep at the same night. I don't oversleep. They're not down to the minute, but even an hour or two off, they think that's the same time. But the phone usage, and that's the first thing they pick up if they can't sleep, if they awaken in the middle of the night.
Right.
Yeah.
We talk about that, and I'll even tell them, even your phone charging on the charger that has a blue light coming off there, that can trigger your brain to think, I need to be awake. There's a light in the room. So that's key. And then I often will ask them, what's your routine? And if I hear reports of, oh, I usually go to bed, at 2 a.m. and then I'm waking up at like 12, 11, like that's when I start to kind of get into, this doesn't really sound like a routine. And I like, why are we going to bed at 2 a.m.? What were you doing before that? I like to watch TV, so maybe we don't need to watch TV. Maybe we need to cut the TV off and do some reading.
I like that. I think that's a good plan. Those phones and not silencing them or using them as the clock to know what time it is.
Yes.
We've gotten away from alarm clocks. We're just using our phones. I like that. Let's get into the over-the-counter and the homeopathic. I love talking about that. I mean, I love lavender oil. I just think it smells so great. Chamomile tea, does it really work to kind of help turn things off? Tell me what the research says about it.
Yeah, so all of those interventions are research driven. And yes, they have results show that they have limited or no adverse side effect profiles. So they're very safe, especially the aromatherapy use of lavender versus like an ingestion or putting it topically. And then the cherry juice as well. All of that's reported in the literature to have an overall calming effect and promote sleep.
That's just like telling when your grandmother used to slather you with Vicks vapor rub and it helped for a cold. And then literally we did the research. We're like, yep, grandma was totally
I guess it
right.
did. Yeah. A warm bath, research shows, it helps get rid of that virus faster.
Yep, I love it. So cherry juice, tell me about that. What does the research show on that?
Yeah, so it's not huge evidence of like, 90% of patients, but it is enough to be reported in the evidence to say that it could be an intervention that is supported in small portions of the population. And again, all of these I look at like they work together. They're an adjunct.
Yes.
It's not like solely I'm just going to drink cherry juice and I'm going to be better.
Yeah. Okay. I get that. As long as you're not drinking your Starbucks at 7 p.m.
Exactly.
also.
Exactly. And don't go to bed at 3 a.m. after watching television. Yeah.
Yeah. The
Put it all
television.
together.
Yeah. All those things. Let's talk a little bit about, I want to talk about when we decide to make prescription level decisions and what that is, what drives us there. A little bit about the over the counter. First of all, you said you treat pain. So a lot of my patients are aging and they just have general osteoarthritis, right? They're sore, they've used their bodies. Doesn't over the counter cut it? Should we start there? Something like ibuprofen or Tylenol, and do we pre-medicate before bed to try to get them where they need to be?
So I get into the routine. I will often ask patients too, like, what time of the day is your pain worse? Do you notice it worse at night? Maybe we need to time the medications to where we take an immediate release or a rescue at night versus the day. Maybe the NSAID that we're taking, the ibuprofen, perhaps that needs to be right before bed versus midday. Just thinking through that. So I do time it that way. Tylenol PM has that antihistamine component in it. I do have a lot of patients that utilize that and they do feel like that works for them. And then they don't have to take more than one medication. So they're kind of getting like a pain relief and then some of the sleep medication as well.
Yep. So any of those NSAIDs that have a combination with diphenhydramine in them. Tell me a little bit about what that looks like on a PRN versus a daily. What should we caution patients about so they know we don't want to just say, yeah, you should just take this.
Yes, no, I love where you're going with that, Terry. I never just say the solution is a pill, especially when we're talking about sleep. So I would prefer it to be, and I recommend it be as needed. And my education to patients is usually, let's look at activity during the day. I would like to be getting up and going to bed at a certain time of day. And I want to know that there's been function throughout the day and activity. And that can slowly be increased for patients that aren't used to that activity. But the more activity and performance we do, we know does have a correlation on not only their well-being, but improved sleep as well.
Okay. Activity and functionality. So first we're going to treat pain if that's what patients are having. But when we get to sleep hygiene, we want a set sleep and wake up time all the time, whether it's the weekend, whether it's the daytime. And when they're awake, they should be functioning. They don't need to be going back to bed 2 hours at a time. Okay.
Yeah. And a lot of my patients too, we have to sort of walk through that. If they're used to napping for 2 hours in the day, let's start cutting it back a little bit. Let's start establishing a routine. Some people like to be pretty aggressive with that and they realize, oh, you know what? I haven't been on a routine. I'm just going to tough it through for a whole day and be exhausted, but I'm going to go to bed at 9 o'clock at night and I'm going to get up at 7 a.m. And then we kind of reset ourselves.
Oh, I love that. I've become a huge fan of 15 to 20 minute yoga nidra breaks during the day, and that taught progressive conscious rest and relaxation in the middle of the day.
Right, which is more energetic too, right? To have that conscious rest.
Yeah. Plus, it's just like a brain massage in the middle of the day.
Definitely. I do a simple thing is just stepping away and listening to a 10-minute podcast or 10 minutes of this podcast and then break it up throughout the day as I'm getting some space outside.
I love how you threw that in there. We're definitely not calm.com, but yes, get that in there.
Right.
Shout out to the Friends of NPACE. Okay, so we definitely want to do that. You know, there are some advantages to the over-the-counter because you're going to get NSAID control, definitely with the pain. And then we've got the diphenhydramine in there, which will kind of help people relax and go to sleep. But long-term everyday use of those medications, there's some emerging evidence that there may be a little concern, especially in our population who's maybe at risk for falls or elderly patients.
Yes, and then in my population, when we're already suppressing the central nervous system, we really don't want to put more medications into the system as well.
Yeah. And again, it depends on where the pain is and what it's doing. If someone's been out in the garden all day and it's muscular pain, some diclofenac topical gel or Arnicare gel.
Love that. Or just a muscle cream that's got a nice combination of all sorts of things in there. They have a plethora of over-the-counter muscle creams that are usually really helpful, or some Epsom salt soaks before bed can be really helpful.
Oh, yes. I love Epsom salt So because it has magnesium in it, again, our grandmas knew what they were doing. Magnesium.
Throw some essential oil in there and you're good to go.
Yeah, totally agree. Okay, I think that's a really important stepwise approach to treatment. So of course, you're going to treat their pain first. You give them some sleep hygiene to do and say, hey, look, let's try all of these things in combination and maybe some over the counter. At what point do you say, either with the sleep portion, of course, you're managing their pain, do you say it's time to think about a prescription medication?
Yeah. So my stepwise approach is screening and assessment, ensuring that underlying pain is controlled. So that's step one. Prioritize my non-pharmacologics. I've done my sleep hygiene. I've focused on their routine. I want to be aware of any CNS depressant medication that they're taking. I also want to assess for misuse of medications as well as substance abuse or misuse. So that's huge, important part to think of. If these aren't effective, then I do consider an antidepressant classes and again, referencing the biopsychosocial model, making sure we're looking at mood and sleep. So I really like that consideration for my stepwise approach. And then, of course, you could look into sleep studies as you get to know the patient. And then I'm always assessing for behavioral health needs too.
I love that's a part of the process all along.
Right.
Okay. Writing that down as well. All right. I really like that. And then you're going to start, because there is usually a behavioral health component to all this, and those are the prescriptions. If we're controlling pain, then behavioral health is probably the next step. I do like that.
Even like, I mean, you're in primary care, you're treating a person. A person has experiences all the time. So you don't know how those experiences might be impacting their mental capacity and their ability to perform and cope.
Yeah, I completely agree. What happens once you get a person sleeping well? You get them on a schedule and you see them again. How do they typically come back to the office with you? Is there?
And usually we just have a discussion, and that's kind of on my radar. If I've diagnosed that, I have it as a problem that I'm constantly reassessing. And I do have excellent results with that. And usually trazodone is what I'll use. If I'm using an antidepressant, I start low, try to use the lowest effective dose. And to your point, I'd like it to be a PRN use as we work more on the other interventions.
Okay. So all of these are typically a PRN use. I'm going to get tangential here. With melatonin over the counter, what do you say about that? And do you encourage that as a PRN use also?
Yes. Anything that I prescribe, I utilize as PRN. And I usually ask them. I have a whole list of medications, and I just keep a record of did it work, did it not work? And I'll just ask the patient, like, is that working for you? And then I'm also asking about those other interventions. What's the bedroom look like? Are you on a routine? What's your daily function looking like? What are you doing throughout the day?
Okay, I like that. Don't put your home office in your bedroom, people.
Yes.
That's where you sleep. The bedroom is for sleeping.
That would be quite the distraction if it were my case.
Right. The children are distraction enough. They come in there all the time. Yeah. All right. Any key precautions in all of this, or things that a primary care clinician needs to go, it's time for me not to be the person to manage this thing anymore, and they need to go to specialty, whether it's pain or sleep medicine or mental health?
Yeah. I would say assess for underlying causes, making sure you're addressing the root cause, assess for risk of dependence and addiction, monitor for side effects, especially when we've got patients that are having on multiple drugs, like we were talking about, monitoring for drug interactions, making sure that there's not an interaction potentially between drugs, and keeping in mind supplements and herbal remedies, that there could be an interaction with those as well. A lot of times patients will take supplements and not tell their healthcare provider because they think, oh, it's natural and it shouldn't matter, it's complementary, but you never know. So we always need to be considering that. And then individualize our treatment plan, making sure that we're curtailing it to the patient's needs. And then overall, I would just advise, as we all know in healthcare, just stay informed on best practices. We know guidelines change all the time. So keeping informed of the best practices is really going to be the safest bet.
Okay. I appreciate all of that. On a tangential side note, like I work in the endocrinology side, diabetes, obesity medicine. And so in my mind, I already know the drugs that will make those things worse. Like this is
Right.
going to make your diabetes worse. This is going to drive up your blood sugar. Are there drugs that we know that'll either increase the perception of pain or interfere with sleep that you like keep on your radar for interaction when you're looking, other than we should be telling everyone anytime we put them on steroids, please, you may
Yes.
not sleep on this
Steroids.
medication.
Oh, that's definitely one, especially for patients with cancer. But I even look at like caffeine intake, and
Okay.
then are they on weight loss medications like phentermine? Like, is there something like that they might be taking that kind of might get the heart rate a little jacked up, and perhaps we need to talk about timing.
Yep. Wellbutrin and some of those more medications to help people with depression or to feel more awake, depending on when you take them, I've noticed.
Yes, and I do tend to advise those be taken in the morning versus taking them at night.
Yeah, or moving from a 24-hour formulation to an SR from an XL.
Absolutely. Absolutely.
Yeah. Okay. And it's amazing how many people don't know that, and people just write scripts and just assume.
Yeah, and to your point, like, thanks for bringing that up, considering what is the patient taking before considering something like trazodone. Like, I actually recently had a patient this week that said, oh, well, the clinician prescribed 25 milligrams, but I upped it and doubled it, and now I'm taking 100 milligrams, and I'm looking at the med profile, and I'm like, you're also on Wellbutrin, though. Did you realize that we've got two different medications here? And it's like, oh, yeah. So that can be essential for assessing for risk.
The interaction part is really important. That's why some of these over the counters are just great if you need them, if you know it's going to be a bad night or you didn't have a great day. It's that dependence. I think there's a component of sleep anxiety in this for people who've struggled with sleep and they just get so ramped up they just don't think, and especially if they have a ticking clock in the morning to get up for.
Right. And then if they do have sort of that anxious type personality, sometimes they just want a quick fix and they just really want to go right to that prescription, something strong, something to make me sleep. But that's not necessarily what's best for the patient, especially if we are dealing with some behavioral health issues.
Yeah, I think it's really important to get back to those. Okay, great. Any key cautions or parting thoughts that we need to tell our audience about?
Overall, I would just say perform a holistic assessment of the patient to make sure you're giving an individualized, comprehensive treatment, and focus on that education and non-pharmacologic approaches, always keeping in mind behavioral therapy and movement treatments as well.
Okay, I like that. I've been even recommending more cognitive behavioral therapy for sleep recently, even for sleep disturbance. And patients get they're like, I don't need therapy for this. But like, it's different. It's like
you have to get buy-in before you go down that road for sure, but it does. And the research does support it, and it's safe without adverse events. So it's really a great tool. What I say is a tool to add to your toolkit. Like, we don't just rely on one thing. One thing would be medicine management. Why don't we use multiple things? That way we make sure that we address you holistically.
I like that. Especially when you may have multiple sources of pain or what's feeding into them not sleeping. But definitely with the numbers we talked about for sleep disorders and chronic pain, that intersection is real. I wonder if you drew a Venn diagram, how much of that is encompassed by the other.
Actually, you're right. Yeah. And how much you would impact, because I do see it all the time for patients. If I can address this sleep component, they get better sleep, they're well rested, and it turns out maybe they don't need so much pain medicine during the day. So it absolutely has a relationship.
Yeah, I think that's really important to say. Well, thank you so much for being here. If people need to find you, they can find you at Vanderbilt or with the PMAAPP.
Yes, absolutely. Would love to network at the fall conference.
Oh, lovely. Yes. So they'll find you there. I love that we have a specialty organization addressing that. I think it's really important for all APPs. Thank you, Dr. Jackson, for taking time. It's been a great conversation. Took all the notes. A big thank you to Haleon for supporting this education. We will have CE credit with this. You're just going to have to take the pre-test and the post-test when we post this. So be sure and check that out at learn.npace.org. For other things NPACE, you can find us at www.npace.org. We're an ANCC accredited provider of continuing education for in-person CE, and we will have AAPA CME credit for this particular one also. So a big thank you to everyone, and we'll catch you on the next podcast. Thanks, everybody.
Thank you.